So it's a pleasure to have now our second in-person event in continuation of our series for the Pioneer in Cardiology. So again, I just want to briefly thank the Daniel and Hetty Whitebrook and family for their gift to support the Pioneers in Cardiology program. We had to go on hiatus for COVID because this Pioneer in Cardiology program is really the fundamental is having the person here and being able to interact with the fellows. And you know, we're really delighted that we're able to restart, and not only to restart, but with a bang with our guest today, Dr. Bonow. You heard a great lecture from him last evening, and I'm sure you'll be delighted today, this morning. Just for everyone to realize, we also have a whole program. You should have got it in your email for those of you on Zoom, or the programs out here. He'll be meeting with the fellows afterwards for career advice. Then we have research presentations over in the CRB at 10 o'clock, and then a noon session on his viewpoint as an editor in cardiology. So please feel free to join us for any and all of those things. And without further ado, call on Laura to introduce Dr. Bonow, our Pioneer in Cardiology, and then at the end, we'll make a quick presentation.
Hello, good morning. So I am honored to introduce Dr. Robert Bonow, who is the Goldberg Distinguished Professor of Cardiology at Northwestern University. Just a little bit about him. He began his career in medical school at University of Pennsylvania, and then went on to pursue his fellowship training at the NIH, where he eventually became the senior investigator at the cardiology branch of the National Heart, Lung, and Blood Institute. He then went on with his career to become the chief of division of cardiology at Northwestern University from 1992 to 2011. He has had a very long and illustrious career and has co-authored numerous papers and many book chapters as well. He is also the editor-in-chief of JAMA Cardiology and is one of the editors of Braunwald's textbook of cardiovascular medicine. He has won many awards, has served on many boards, been president of the AHA as well throughout his career. And we had the pleasure of having dinner with him last night. And I had also the pleasure of speaking with him a couple of weeks ago and interviewing him. He is a very distinguished, wonderful human being to speak with, and also very impressive in terms of his career. And so I'd like to welcome you onto stage, Dr. Bonow. Thank you so much for coming.
Well, thank you, Dr. McDermott. Again, it's a great pleasure to be here. And for me also, a part of the honor is helping you kind of reawaken how we do presentations like this in person, as well as obviously those of you tuning in on Zoom. And Jeff, Dr. Goldberger and I go back exactly 30 years, talk about anniversaries. And I came to Northwestern, as we'll discuss, in 1992. Jeff was already up and rolling, and full force. It was a true loss for us when he left and came to Miami. And I'm sure you're all in his arms and doing quite well as you move forward here. So, Dr. Goldberg, thanks for the invitation to be the pioneer. I mentioned yesterday, when you call the pioneer, you wonder what the statement is regarding where you are in your career. I was delighted that Dr. Braunwald was your first pioneer, and he's still very active, and I hope to be too. So if you'll indulge me, this is going to be a discussion of kind of my career through 50 years of valve disease and the aortic valve, but we want to look forward as well as backward. But there's a reason why I chose 50 years, no relationships to disclose. 50 years ago, exactly 50 years ago, 1972, I was a third year medical student and doing my cardiology rotation. And so here I am at the University of Pennsylvania, 1972. My first patient is a patient with aortic stenosis. So what does a medical student do? You go back to your first and second year notes. Medical education was different back then. We didn't have PowerPoints. We didn't have PDFs. You know, what we had were these mimeograph sheets that I had pulled out, and you can see I'd scribbled all over it. I was learning about systolic gradients and pressure overload and volume overload, Laplace relationships. But I found this because, as Dr. Goldberg knows, we're downsizing my house and moving. And so I had to go through my files and purge my files. And I found this piece of paper, 2 pages. And said, oh yeah, this is what got me started, because it's not the notes, it's the one reference here. There's one reference down here by Morrow et al. That I still had in my files. Here it is. It's been purged, but now I have it electronically. This is what often happened were these staff conferences from the NIH that got published in the Annals of Internal Medicine. And this one was from Morrow et al. And you can see kind of the cast of characters he was dealing with here: William Roberts, John Ross Jr., Dean Mason, Eugene Brownwald. For many of you, these names may not be familiar except for Brownwald, but for us, this was like the Gas House Gang. This was the group of really active investigators. And the ringleader here was Andrew Morrow. Andrew Morrow was a surgeon. The history was that the NIH decided in 1948 to build the clinical center, this big research hospital. It was opened in 1953. They recruited Dr. Morrow, surgeon, from Hopkins to be the director of the National Heart Institute, the clinical version of that. And Eugene Brownwald came a year later, 1954. And it was under the structure that Morrow created that allowed Brownwald to kind of rise in prominence. And his research career was all dependent upon what Morrow had created. And so I read this paper and I said, I want to be like these guys. And so as a medical resident, shown here, standing, I'm the tall guy with the afro, standing in the back, behind Arnold Relman, who was our chairman before he went to be the editor-in-chief of New England Journal of Medicine. So as a resident, I applied to the NIH, the same kind of training program that attracted Dr. Brownwald a couple decades earlier. And I was successful in getting in. They chose 6 clinical associates each year. I was one of the clinical associates. And so I finished my training at Penn and parachuted into the clinical center at the NIH. Now, those of you who've been to the clinical center at the NIH will not recognize this photo, because this is what it looked like, 50 years ago when I went there. But it's now all paved over. The green grass is gone. It's kind of an urban landscape. But this was a 17-story brick building with 504 beds for clinical research. And I thought I was going to do 2 years there and then move on, but through your tax dollars supporting my research and very productive mentorship, I stayed on for the next 16 years. And part of this was driven by my interest in valve disease and these investigators who had been studying pressure overload and the effects on left ventricular function and outcomes of patients. And I was there in the nascent days of echocardiography and working with Walter Henry, who was one of the early pioneers in echocardiography. And so you can see my first 2 papers there were with Dr. Morrow, the surgeon, Walter Henry, and Steve Epstein, who was a branch chief. And Henry and Epstein, along with Morrow, were my early mentors. So we were doing some new things with echo. It wasn't so much for diagnosis, it was trying to track how you could use this tool to look at outcomes. And so for aortic regurgitation, it was measuring left ventricular function, ejection fraction, and systolic diameter. For aortic stenosis, it was looking for a regression of LVH after AVR. Dr. Morrow died tragically around 1982. Dr. Henry moved on to be ultimately the chief of cardiology, chairman of medicine, and provost at UC Irvine. But I stayed with Dr. Epstein for the next decade and a half or so. And we were able to follow with echo a series of patients looking at the natural history of aortic regurgitation, long-term studies in asymptomatic patients with initially normal ejection fraction. And what popped up was this, again, this end systolic diameter. I'm only showing this because if you look at the guidelines in 2020, this is the index we still use for when to intervene for aortic regurgitation, which for me is still a problem. Why are we still using this index? So we'll go there in a second. And so Dr. Epstein was my mentor. This is me when I'm leaving the NIH and joining Dr. Goldberger and colleagues at Northwestern. The APRO is gone, the bell bottoms are gone, kind of grown up a little bit. Dr. Epstein's mentor was Dr. Brownwald. And so mentorship carries on generation to generation. And so we learn from each other. So the whole concept of pioneer, I mean, I'm a little uncomfortable with that. I don't consider myself a pioneer. I consider myself a kind of a transition point. You know, we pick up the pieces from others, we move the ball a little bit down the field, and then we hand it off to the next folks. And Dr. Brownwald is a great example of that. So not only was he the mentor for Dr. Epstein, he turned out to be my mentor as well, because I had met him a couple of times during the early stages of my career. Then he invited me to write a couple of chapters for his book. And then another anniversary point for me is that 20 years ago, he invited me to be one of the editors of the textbook. So here I am with the other editors at the time, Doug Zipes, Peter Libby, Dr. Brownwald. And in my first rendition of this book, Dr. Brownwald came to me and said, Bob, we need to update the valve chapter. So I'd like you to redo the valve chapter. And I said, well, of course I agreed to do that. And I said, but you know, Dr. Brownwald, it's like being given a Beethoven manuscript and being asked to make better music. You know, it's kind of hard to outmaster the master. It actually did need some fine tuning. So we did that together and moved on. So that's kind of the ancient history of my anniversaries. 50 years with my first patient with aortic stenosis, 30 years moving to Northwestern, and then 20 years with this textbook. But so what's happened in 50 years? Let's think about what medicine was all about. Not only did we not have PDFs and PowerPoints, but we also didn't have a lot of what we think is modern treatment for cardiology, heart failure. Treated with bed rest and digitalis, and if you could get your hands on intravenous furosemide, you could use that too. That was treatment for heart failure. Treatment for acute myocardial infarction, bed rest, oxygen, and morphine. There was actually questions about whether you should give a anticoagulant medication or not, because it wasn't even clear then whether the thrombus in the artery that was found at postmortem was a postmortem event, as opposed to a causative event. Thrombolytic trials were just starting at that point in Europe. So for valve disease, what's transpired? Well, all the imaging we do and all the even biomarkers, just totally unavailable in 1972. Things like three-dimensional imaging with CT and MRI, you know, it's not there. These are all pie in the sky kind of things. It's kind of like, you know, you now have a wristwatch that was what Dick Tracy was using back in the 1950s and 60s, the two-way little radio on his wrist. Yeah, we never thought we'd actually have one of those. Other things, treatments, bioprosthetic valves, minimally invasive surgery, transcatheter valve technology. I mean, just way in the future. Randomized clinical trials, clinical practice guidelines, not available, 1972. And of course, the multidisciplinary heart team, which I think has really helped to transform our care of patients, is also something that was not doable back then. And so it's been very interesting to watch this happen. Now, if this has happened in my 50 years, imagine what's going to happen in your 50 years. You know, it's going to continue to move forward, and it's moving forward at a very accelerated pace. So enough history here, let's kind of move forward and talk about what the progress has been in aortic valve disease. And so I've decided to make this in 3 chunks, bicuspid valves, AR and AS. Let's start with a bicuspid valve. As you know, it's very common. It's 1.5 to 2% of the population. Over 50% of our patients who come to valve surgery have bicuspid valves. And of course, the other thing we need to know about our patients with bicuspid valves is whether they have a disease of the aorta. And so when I was a fellow, the thinking about why patients with bicuspid valves have dilated aortas was because of the post-stenotic jet, the post-stenotic dilatation created by the jet from a bicuspid valve. So it's kind of a mechanical hemodynamic effect. Things changed in the era of cellular and molecular biology with a number of studies showing that there's actually some cell-cell signaling abnormalities, probably related to the genetics of a bicuspid valve, which is another thing which needs to get unraveled. And so good data from numerous laboratories showing that there's abnormalities in the aortic matrix with increased degeneration of elastin and collagen-rich matrix, increased expression of metalloproteinases and decreased expressions of the tissue inhibitors of metalloproteinases. Smooth muscle cell apoptosis, and in particular, excessive TGF-beta signaling. Some of the same things that happen with Marfan syndrome, probably but at a lower level. And so this shifted from being thought of as a hemodynamic effect to more of a cell-cell biochemical effect. But stay tuned, because things continue to change, and sometimes they circle around and come back and come to you, because maybe there is something related to the jet effect. This is a 4D flow MRI from Michael Markle at our institution. I'm not showing you a normal example, which would be laminar flow, but when you have a bicuspid valve, you get these high pressure vortices being created that then circulate around in the ascending aorta. When we first started doing this, I thought it was great imaging. It's pretty fascinating. But is it clinically useful at all? Well, further studies in more than a single patient shown here, in this case by Mahadevi and co-workers, kind of point out the obvious. If you have a bicuspid valve, it's because you're fusing 2 of the leaflets. And depending on how they are fused, whether you have right-left cusp fusion versus a fusion involving the non-coronary cusp, those jets go in different directions. And then from that, you can create these heat maps of where the wall stress is greatest. Again, interesting imaging. Is it clinically helpful or not? Follow that up with a paper by Guzzardi, who David Guzzardi was a MD PhD student at the University of Calgary, working with Paul Fedak, who has a joint appointment with us at Northwestern. And we studied a series of patients who were not only being imaged, but also having surgery to fix their aortas. So we could get tissue. And what was shown is when you have these heat maps, the areas with normal wall stress have pretty much normal histology, where the areas where the heat maps are hot, where you have increased wall stress, that's where you have the abnormalities of the histochemical abnormalities of decreased elastin fiber content, increased metalloproteinases, and increased TGF-beta signaling. So it's related to where the wall stress is greatest. So there's this combination of a genetic predisposition for badness, which is then turned on by these pressure effects of these vortices. We've now studied, easily 800 patients. Have some follow-up data indicating which patients progress more rapidly. It's the ones who've got all those red spots. That's then leads to some patients who require complex surgery involving aortic root replacement. And the current guidelines for that, as you know, are somewhat arbitrary. We need some better data, but it's these are the thresholds we use of aortic diameter, 55 millimeters in the absence of risk factors, 50 millimeters if there's been rapid progression or a family history of dissection, and then 45 millimeters in an individual who has the otherwise indications for valve replacement for AS or AR. But lots of unknowns. What are the areas of uncertainty? Okay, the genetic markers here are very complex, not well sorted out. You do see it in some families, but usually you don't. Valve orientation and aortic disease, risk of dissection. Where do we come up with those thresholds? They're debatable and controversial. And how often should we follow patients? We've got a dilated aorta. And then the issue of echo versus MRI or CT. I think every patient deserves at least one advanced imaging test in one's life. And in some patients, we do a lot of MRIs, only just to follow the serial development of the disease, because it's got less radiation than the CT. So these are areas of active investigation. Let's move on, talk about aortic regurgitation. We're taught that this is a disease of volume overload, which it is. So you have this preload effect. What's often not emphasized is not just preload. This is a very complex lesion, which also has an afterload effect, because that wall tension created by the regurgitant lesion, which causes the increase in preload, also increases wall stress, which is an impedance to ejection, and that's why there's an afterload effect here as well. And so the preload creates an increase in volume, the afterload leads to LV hypertrophy, so there's an incredible increase in left ventricular mass. Probably more mass with AR than you would get with a patient with severe hypertrophic cardiomyopathy. And so that's illustrated in this little diagram from Rick Nishimura. When you blow up a balloon, the wall gets thinner. When you have a dilated cardiomyopathy, you usually have reduced wall thickness, but with AR, the ventricle gets bigger and also gets a lot thicker. That concept actually also resonates with me because I was aware of this paper in 1975 from Bill Grossman, pointing out essentially what the Laplace relationship really tells us. If you, this is a kind of an iconic diagram from Grossman that you may have seen in textbooks as well from 1975. Aortic stenosis is pretty clear what this does. It's a pressure overload leads to concentric hypertrophy. With aortic regurgitation, the volume overload leads to chamber enlargement. That increases the wall stress, that increases the thickening. And so you have what's called eccentric hypertrophy. So it's a combination lesion, which is actually quite interesting and quite complex. So the indications for intervention for aortic regurgitation, these are the current guidelines recommendations. Symptomatic patients, clearly, but in asymptomatic patients, it's an ejection fraction of less than 55%. And then we have these echo measurements, severe LV dilation. There are 2A recommendations. But what's striking for me is that we're using this LV end systolic dimension of 50 millimeters. That's something, I was part of the propagation of that concept. It's still here. So why are we still using that? And now we can index it to 25 millimeters per meter squared. In fact, that's come under some debate also, because we have 3 going on 5 papers, which have shown that perhaps that threshold of 25 millimeters per meter squared, which is based upon one study from the Mayo Clinic, to use that threshold. And in the guidelines, based upon that one study in the Mayo Clinic, there's been 3 papers showing that if you draw that a red line here in a series of patients with aortic regurgitation at 25 millimeters per meter squared, and then look at the actual outcomes of patients and where the risk begins to step up, it's down around 20 millimeters per meter squared. These are 3 papers from Mayo Clinic, Cleveland Clinic, and a consortium in Europe. Kind of muddy data, because it's some symptomatic patients, some asymptomatic patients, some went to surgery, some didn't go to surgery. That's why we didn't change the guideline yet, because it's not really good prospective data. But we're seeing more of this too, so that maybe we need to lower that threshold. But for me, the real question isn't what's the threshold, it's why are we still using a linear dimension in a 3-dimensional chamber, which can dilate in all kinds of different shapes and sizes, because the shape issue, you have a basketball, you have a football, when the ventricle dilates, and a linear dimension is just not there. So it was over 10 years ago that I was invited to write a editorial for JACC Imaging, and this was kind of my conclusion. Okay, where are the left ventricular volumes? Are we looking at interstitial fibrosis with hypertrophy, global longitudinal strain, biomarkers? And here we are, 10 years later, and we're still not there. Things are starting to emerge. We certainly have MRI data. We're going to be publishing one soon in our journal using MRI. But with MRI, one can not only get excellent, accurate volume measurements, but you can also get excellent regurgitant volume index measurements as well, probably better than you can do with echo. So we need to start using more advanced imaging. We did publish a paper using two-dimensional echo-derived measures of volume. And this paper by Yang and co-workers looked at end-systolic volume index and death in patients with aortic regurgitation, and came up with a cut point somewhere around 45 milliliters per meter squared as an endpoint for where one would start seeing a adverse outcome. And when they dichotomized the data shown here, indeed the individuals who have an end-systolic volume index greater than 45 was where they had the higher risk. End-systolic volume is a good concept because it brings in both systolic function and degree of dilatation. That's why the data are usually stronger with end-systolic volume than they are with end-diastolic volume. And so the other interesting factor here is if you look at the ASE guidelines for defining what is, normal, mild, moderate, severe dilatation, 45 millimeters per meter squared is the threshold to claim it's severe dilatation. So that fits quite nicely with the ASE guidelines as well. This needs a little more validation before it becomes mainstream, but at least it's moving things in the right direction. But nothing really unique. The whole concept here was thought of years ago. In 1980, working with Bill Grossman, Ken Borrow published these data in patients with aortic regurgitation, looking at who had an improvement in systolic function after valve replacement. And they were looking at end-systolic volume index. And for them, the threshold was 60. But in patients who had an end-systolic volume index greater than 60, there was no improvement in systolic function after surgery. So the concept was there. What was missing was a tool. This is an invasive angiogram. And so we can't do that, serially in asymptomatic patients. And now we can. With MRI or CT or hopefully with echo. And then MRI, of course, can give you more information. This thought process for interstitial fibrosis, myocardial interstitial content, as well as late gadolinium enhancement has been out there for aortic stenosis. And I'll talk about that in a few minutes. Just beginning to get studied with aortic regurgitation, because remember there's a lot of hypertrophy here and a lot of interstitial myocardial changes. And then global longitudinal strain ought to be factored in as well. And there's some good data from the Cleveland Clinic by Alashi and co-workers following patients with who are asymptomatic, have significant aortic regurgitation, and showing that there's also a good marker here from echo using global longitudinal strain as to who would be at higher risk for mortality. And the peak, the value they found was roughly around minus 18. Look on the right where they have the group that did not go to surgery, that those curves become quite steep after minus 18. But even in the AVR group, there's a signal here as well after AVR. In fact, they had a larger series where they followed patients after AVR longitudinally out for, as you can see, over a decade. And the individuals who had the worst GLS pre-op had a worse outcome after surgery as well. So what do we do? Many times these are young patients. This is a 26-year-old, severely dilated ventricle. He's asymptomatic, wants to run marathons, got a bicuspid valve. You can see the valve's prolapsing, horrendous aortic regurgitation. Fits all the criteria for surgery based upon the non-invasive test. So he's 26. And what's the right valve for him? The standard recommendation is this debate between a mechanical valve versus a bioprosthetic valve, with the obvious downstream issues we're going to deal with depending upon how we make that decision. And hopefully involving the patient in that decision too. Why can't we do something else? Why can't we repair the valve? are there centers that can do a Ross procedure? Indeed, we can in highly selected patients and in highly selected surgical teams with very good outcomes. Again, in a center which has devoted itself to perfection, or as much perfection as one can do with these techniques. So there's data from centers mostly in Europe with repair of aortic regurgitation, not yet as mainstream as it would be for mitral valve repair. But excellent results. Here is 1,000 patients, 15-year survival of 82%, with a 10-year reoperation rate of only 8%. This is a center in Germany, which has been doing this for decades. But a patient of mine had this done at a center in the United States because he wanted his valve repaired. He was 46 years old. Here's his pre-op and post-op echo. His LV diastolic dimension has decreased from 68 millimeters to 49 millimeters, about 6 weeks post-op. And of course, it's the decrease in diastolic size, diastolic volume, which predicts the long-term outcome. Have you really decompressed the ventricle? And you see that usually within a week of surgery. But more importantly, you got to move beyond these linear dimensions. His end diastolic volume index was halved by surgery. His end systolic volume index was dropped by 2/3. Remember that 45 millimeter per meter squared threshold that we said was a sign of badness if you're above that? Well, he was at 62 ml per meter squared, but it dropped to 23 ml per meter squared after valve repair, and his EF increased to 71%. He's out now 1 year. And so that's the whole issue with aortic valve repair, is the durability of this. He's doing well a year later. We'll see how he does over the next decade. But at least we've, at this point, saved his valve for future work when he may require a valve replacement in the future. And then there's the Ross procedure. We were doing a lot of these in the 1990s. It fell out of favor. We started doing it again with a different surgical technique and different surgical team with thus far very good results. As you know, that's removing the aortic valve, replacing it with the patient's own pulmonic valve, so it's an autograft, and replacing the right side with a homograft. So again, not for the faint-hearted. It's a tricky operation, but in excellent hands can lead to really good results. These are multi-center data that we published last year. 5 centers in Canada, Australia, and Europe, again, having devoted themselves to this methodology, showing a 15-year survival of almost 90% and a 15-year reoperation rate of only 11%. You got 2 valves that can go wrong. You have to replace the coronary arteries. It's complex, but can lead to really good results. A U.S. study from El Hamansi and co-workers looked at U.S. data in New York versus California in patients getting mechanical valves, bioprosthetic valves, or Ross procedure. It's not a prospective trial. It's retrospective propensity match data, which you always have to take with a grain of salt. But they did show that the individuals getting the Ross procedure had a risk of mortality significantly less than the individuals who got the mechanical or bioprosthetic valve, and reoperation rates were higher compared to a mechanical valve, but ultimately lower than with a bioprosthetic valve. So there's certain centers in the U.S. now which are doing more work with the Ross procedure. What's the right operation for a 25-year-old woman who wants to be a mother? And there's risks with mechanical valves, risks of bioprosthetic valves. Ross procedure might be a procedure that could allow patients to go perhaps decades before more definitive surgery is required. So anyway, those are the things that are going on in my mind with aortic regurgitation. Let's talk about aortic stenosis for the remainder of the hour here. Again, my training was when you see a calcified valve like that, it's like a rusty gate that's been left out in the rain. There's been some passive wear and tear and calcification. We now know that this is not the case. This is a very active, proliferative, inflammatory lesion that perhaps could be modified with medical therapy. We do know from data such as these from Dweck and co-workers using PET-CT to look at both ossification and inflammation with PET, localizing to the valve using the CT as your landmark, identifying what would be normal mild AS or severe AS, and the individuals with severe AS have higher signals of sodium fluoride as a marker of calcification, and also in the same areas, fluorodeoxyglucose as a marker of inflammation. And they have a second study where they followed patients serially and showed that areas of inflammation that had not yet calcified over the next 6 to 12 months began to calcify, where the areas had previously been inflamed. So that's one signal. The other is the genetics of this. Is there a genetic predisposition to who's going to develop calcific aortic valve disease? This is a large GWAS study of about 45,000 individuals with both internal and external validation across the world, including multiple ethnicities and races. And what was found by Thanasoulis and co-workers in this seminal paper in the journal is there's a single SNP sitting on chromosome 6 in the locus of LPA, which is the gene that codes for circulating levels of Lp(a). And so Lp(a) has become one of the discussion points for perhaps a target for identifying individuals at risk, but also maybe a target for therapy in the future to slow down the process. This was a study of looking at who would calcify their valves, but it's been verified as who would also develop aortic stenosis. This has been shown in this study from Denmark and also found in the Kaiser database in California. But this study from the Copenhagen study followed a series of patients with echocardiography as to who was going to develop aortic stenosis. And what's shown here are the percentile levels of LPA on the left and the levels of LPA in milligrams per deciliter, number of subjects, thousands of people. And once you get into the 90th percentile or greater of Lp(a), there's a increased risk of developing true aortic stenosis with time, and depending upon whether it's just age and sex adjusted or with a multivariable assessment. What was interesting is they had genetic data in these individuals too. And that was quite interesting because that single SNP on chromosome 6, identified by Thanasoulis, is also present when you've got an LPA level in the 90th plus percentile, present in about 50% of the individuals. So maybe there's also a way here of merging the genetic data with the levels of Lp(a) that might be useful in identifying who could be at risk and maybe targeted for future therapies once we have a drug that really drops Lp(a), more so than PCSK9 inhibitors do at the current time. So the model would be that LPA gets into the intracellular space in the valve interstitium. The Lp(a) is then hydrolyzed by phospholipase A2 into phosphatidylcholine and oxidized fatty acids. And the phosphatidylcholine, along with the oxidized phospholipids present in Lp(a), are very pro-inflammatory, attracting macrophages. The signaling then goes to the valve interstitial cell and through a myriad of pathways that could lead to mineralization. Interesting cartoon, but probably too simple. There's got to be multiple pathways here. It can't be quite this simple, and that's illustrated by Brian Lindman's work here, where it kind of looks like the New York City subway map of all the various ways one could get from lipid infiltration and inflammation to a fibrocalcific response. And we've just been looking at this stuff on the left. So there's multiple targets here. So in your future, there's going to be data, I think, showing that one or more of these targets is druggable, and maybe you can slow down the process. We're not there yet, but we're at least moving in that direction. But along the way, as we're talking about what makes a valve calcify, we shouldn't lose sight of the fact that what does that calcified valve do to the ventricle? Because this creates, again, a pressure overload and left ventricular hypertrophy, as illustrated by Nishimura. So LVH and aortic stenosis, marker by definition of the severity of the pressure overload, a compensatory mechanism to reduce wall stress in the setting of the pressure overload. That's the good news. But like any other compensatory mechanism for myocardial overload, LVH has short-term benefits, but long-term adverse consequences. Because this is a contributor to myocardial stiffness, increased end diastolic and LA pressures, essentially creating HFpEF in our patients with AS, and also perhaps a contributor to adverse outcomes as well. This has been studied also in my history here as well, because I was following this field in the 1980s when Hess and Kreinbiel published their data with myocardial biopsies in patients with various conditions, including aortic valve disease. And they actually did biopsies pre and post-op in patients who had aortic valve replacements, showing that, as you might expect, what happens after aortic valve replacement for AS is the LVH regresses. Okay, so the myofibers become smaller, but the collagen, once cross-linked, doesn't go away. And so they actually showed that the myocardial stiffness increased as the LVH was regressing. So you're left with some baggage when you start developing a lot of interstitial fibrosis related to aortic stenosis. Now, this was their study after pre and post-op making those findings. Well, we don't do biopsies anymore. Instead, we could be measuring the same phenomenon with MRI. And so there's a series of really interesting data, if you're in the field, looking at the progression of this and its implications in patients with aortic stenosis. This was one of the first papers talking about the mid-wall fibrosis with late gadolinium enhancement by Dweck and colleagues, and outcomes of patients with aortic stenosis. The interesting one I thought from this group was a follow-up study where they had patients who had MRIs. They all had aortic stenosis, all had normal ejection fractions, and there was one group with normal myocardial tissue imaging, one with extracellular expansion with T1 and T2 mapping, and another group with frank replacement fibrosis and LGE, late gadolinium enhancement. And when they looked at those three groups, clearly the ones with the more intense fibrosis had more severe AS, peak velocity was higher. They had greater left ventricular mass. Therefore, they had more diastolic abnormalities. And then interesting thing for me is they were also leaking troponin. So maybe that's why they developed interstitial fibrosis. Maybe it's a replacement fibrosis from a myocardial injury. And so I think the thinking is moving in directions like this, that LVH is a setup for diastolic dysfunction, interstitial replacement fibrosis, but also, and of course the fibrosis leads to more diastolic dysfunction, but also there could be microvascular disease related to the LVH, something we were talking about yesterday, the microvascular circulation, which might lead to myocardial ischemia and injury, and then that feeds back also to make the ventricle stiffer as well. So there's some interesting complex pathways one could follow with further research for those of you who might be interested in this. This is nicely summarized in a wonderful review from Catherine Otto in the Journal of Medicine in 2014. Kind of a must read for our fellows. The must read for me when I was training was this seminal paper from John Ross and Eugene Brownwald, those guys that I was following and decided to kind of follow in their footsteps at the NIH. You've all seen this paper in one way or the other, whether you recognize it or not. This is a picture of Brownwald and John Ross on the left, Edmund Sonnenblick on the right. They're sitting in the green grass behind the clinical center at the NIH. That was when there was still green grass before it got paved over into a driveway. These guys were so prolific. I mean, they were pumping papers out every 3 days into the medical literature over the course of a decade. And I still have this little textbook from Sonnenblick and Brownwald about myocardial overload. But the reason I know you've seen this paper is because this is where they talk about the gray prognosis that appears to accompany the onset of certain symptoms, and where the iconic diagram shows up that you probably anticipated that would show, because everybody shows this diagram when they talk about aortic stenosis, of this natural history of increasing overload, patients doing well, asymptomatic, and they get to the point where enough is enough, symptoms develop, and once symptoms develop, it's a herald that things are going to go bad very quickly, and 2/3 of the patients will die over the course of the next 2 to 3 years. So interesting. Here I am. This was published in 1968. This is over 50 years old. And we actually had a celebration for Dr. Brownwald on the 50th anniversary of this figure at a meeting in New York, where we essentially pointing out that, you know, this is an iconic figure. And I kidded him and said that, you know, Dr. Brownwald, none of your TIMI trials with 30,000 patients is ever going to have a figure that is lasting 50 years like this, you know, and here it is. And the interesting thing, this is not based on 30,000 patients. This is based on 12 patients. I mean, Dr. Brownwald told me that they were sitting at a kitchen table trying to figure out what to do with Dr. Morrow, the surgeon, who was kidding, was nudging them and saying, why are you sending me these patients? You know, we don't know what the outcome is going to be. Is it too early? Is it too late? What's the natural history? And so they went back, they looked at the outcomes in their 12 patients, all of whom had died, and came up with this kind of back of the envelope diagram, which is what they did. There's no data here. It's just a concept. And of course, this curve shifts to the right now, which I've done to match what we see in our population, which is an elderly population now, with the same outcome if we don't intervene when symptoms occur. So the other remarkable thing about this figure, which is an idea and a concept that somehow stayed with us for over 50 years, is that there's patient data that replicate that. These are one of many papers. You know, symptomatic patients unoperated upon show at 3 years, 50% of the patients have died. That's exactly what Ross and Brownwald predicted. This was a paper 40 years later. And this, of course, is pre-TAVR. This is published in 2009. So things might be different now if we were intervening in higher risk individuals with TAVR. And so we'll get there in a few minutes. So that makes it easy for a guidelines committee to make a class 1 recommendation that symptomatic patients with severe AS should have a valve replacement. It's not based on clinical trials. We'll probably never have a clinical trial. So it's not a class 1 level of evidence, strong level of evidence A, but it's kind of a small A. Easy to write the guideline. And when you take your board exam, it'll be an easy question for you to address. Symptomatic patient, aortic stenosis, replace the valve, move on to the next more difficult question. But in clinical practice, is this always easy? You know, are the symptoms cardiac? You know, if your patients are like mine, they're getting older, they're deconditioned, they have arthritis, they're overweight, they're not exercising, and they're getting a little short of breath. And so is that a valve symptom? Better sometimes just to intervene and ask the questions later, but it's not always easy in practice when you take a very simple class 1 recommendation and then say, okay, we're going to implement this now in practice. Not so easy. And then when those are the relatively easy decisions. How about these more complex ones? The asymptomatic patient with severe AS. And we'll talk about low gradient and indications for TAVR as we wrap up. Are asymptomatic patients with AS really asymptomatic? It's kind of the flip side of the previous discussion. You know, patients stop doing things when they don't feel good. They become less active. And so even careful histories can tease out what may be symptoms in patients with aortic stenosis. And so, you know, what is a symptom? What is asymptomatic? What are the outcomes when patients we believe are truly asymptomatic? We do have outcomes data, again, this time from Catherine Otto, 1997. One of the first ones looking at the natural history of asymptomatic AS. She had different gradations of severity, but these were the outcomes in the patients who had severe AS, defined as a peak velocity greater than 4 meters per second. So at 5 years, every patient had an endpoint. It wasn't death. Most of the endpoints were patients developing symptoms. And the 6 patients who died were patients who all had symptoms, either refused surgery or were waiting to get surgery. And these data are not unique. There's a number of other natural history studies since then, which kind of replicate those findings. Not every patient, but most patients with VMAX will have a surgical endpoint within the next 5 years, including several patients who died. And so one could argue, you know, why are we waiting once you've got severe AS, you know, because it's kind of predictable that over the next 5 years, most patients are going to require surgery. It gets to be an easier discussion when you're talking about TAVR in an asymptomatic individual, but we're not quite there yet. So does AVR in these asymptomatic patients actually improve survival? That's the question. If we intervene now rather than later, are we actually going to save lives? So we never had clinical trials until like 2 years ago. And now in the last 2 years, we got 2 clinical trials. Start hanging your hats on. but each one has some things to discuss because they're small studies. There are limitations in analyzing the data. The first one from Kong and co-workers, recovery trial, 145 patients, all in Korea, mostly bicuspid valves, very severe AS, Vmax mean of 5.1. The Avatar trial published just a few months ago in Circulation, presented at the AHA meeting last year. Again, 157 patients, severe AS. The good news about the Avatar trial is every patient had an exercise test, all could achieve 85% maximum predicted heart rate without symptoms. And so they probably were truly asymptomatic. It's not so clear about the Korean study. But when you look at the outcomes, very similar outcomes. Those randomized to surgery, this was not TAVR, this was surgery, randomized to surgery had a better outcome than the patients randomized to watchful waiting. But a couple of comments here. The Korean data on the left, gosh, if you look at the blue curve here, the patient getting surgery, there's no mortality at all for the first 3 years after aortic valve replacement. Now, is that something you guarantee your patients going for aortic valve replacement? So in Korea, there's very little comorbidities, very little diabetes, PAD, CAD. And that may explain why the outcomes are so good in Korea. On the right, where we're dealing with the Eastern European population, more akin to ours, where there was CAD and diabetes and so forth. This was a messy trial, unfortunately. It's 157 patients, but it was powered for 312. It was closed in 2020 because they couldn't enroll patients, and I suspect it was related to COVID. And so it comes in with 50% of the power it was looking for. And they use a composite endpoint of death, heart failure, hospitalization, or stroke. I'm not sure why stroke was added. It was stroke added into the endpoints. So in their composite endpoint, they did achieve significance. But when they looked at mortality, it was not significant. The trend is there, and it's probably true, but it's just underpowered. So it's not significant looking at mortality. The other issue with this trial is that there are 157 patients, but 115 of them came from a single center. And so you worry about a multi-center trial, which is not truly multi-center in nature. But it's moving in that direction. And so maybe we should be recommending early surgery, or in this case, maybe early TAVR. So here's a patient of mine. He's 84 years old. He's got a severely calcified valve, hypertrophy, normal systolic function, has a Vmax of 4.6, translates to a mean gradient of 52, aortic valve area of 0.7. Fits all the criteria for severe AS. Okay, now what do? He asymptomatic, 84-year-old. Watchful waiting, more data, aortic valve replacement. Those are the possibilities, of course. Neither of which is wrong. It all depends on what we do next. What's interesting for me, again, having been part of the ancient history here, is what watchful waiting means currently. For us, we used to watch and wait. In this case, you would wait because we know within the next 5 years he's going to have symptoms. And then he's a candidate for TAVR. He doesn't want surgery now. He feels great. So let's wait till he has symptoms, then he becomes a candidate for TAVR, because right now he's not a candidate for TAVR because he's asymptomatic. So what I did actually was to enroll him in a clinical trial. Are you guys involved in early TAVR trial? Okay, so we have a clinical trial. It's fully enrolled, right? And we're just waiting for the outcomes. So we'll see whether early TAVR leads to a better outcome. This is going to be a good trial. It's much more numerous than the other trials. Lots of good sub-studies with biomarkers, other things. So we'll wait and see. Let's just talk a little bit about low gradient severe AS. This is a real conundrum for all of you guys, and I hope one of you will unravel this for us because it's hard to unravel why some patients come in with low gradients. One group comes in with easily understandable low gradients. They've got LV systolic dysfunction because of the afterload excess leading to a decrease in ejection. And here the key is to determine who's got true AS versus who's got a cardiomyopathy with incidental aortic valve calcification. So we do dobutamine testing either in the echo lab or the cath lab to tease out who's got true AS. Not that this is easy, but at least the physiology is understandable. Patients are difficult because they're sick, and the next steps could be very, very risky. But at least physiology is understandable. What's less understandable is the other physiology of patients with normal ejection fractions with low flow, low gradient, so paradoxic low flow AS. This one is problematic because it's so frequent. Now that we're aware of this, one sees this in 35 to 40% of the patients presenting with aortic stenosis. What's going on here? It could be, as depicted here by Pibero and Dumasel, of a patient with severe hypertrophy, which occurs with age and also occurs especially in elderly women, where you have extreme hypertrophy, which encroaches on your end diastolic volume. So even though the ejection fraction is normal, you're starting with a low LVEDP, and so the stroke volume is reduced. So that's one mechanism. The other mechanism could be hypertension in patients where you have an extra impedance to ejection. And you may have had the experience that others have had where you then treat the hypertension, restudy the patient, and now that the peripheral blood pressure is normal, you now have a higher gradient. So the first thing to do is treat the hypertension. Let's not rely only on non-invasive tests. Let's do a cardiac catheterization too to confirm the physiology. That's not that helpful though, because a really good study of 330 patients in Germany by Minners and co-workers, all who were patients with AS with normal ejection fraction, who had both an echo and a cath, showed that the cath data just confirmed what was there on the echo, that about 33% of the patients have this physiology, what appears to be severe AS based upon the valve area, but low flow, low gradient AS. So we need to do some other things. Is the valve calcified? Are there other things with advanced imaging that could bring out who may have true aortic stenosis? Maybe the myocardial fibrosis story. What's most important is you and I need to be good doctors. Clinical skill set becomes really important, trying to make a decision as to who may benefit from aortic valve replacement and who would not. Clinical skill set's interesting because consider other things that could present with this physiology. Increased wall thickness, low flow, aortic and aortic calcification, and some symptoms. Okay, it can be overdiagnosed now. We used to underdiagnose it. I think we tend to overdiagnose it now because it's been out there. Interesting study from Castagno and co-workers at Columbia, this big center for TAVR. Patients referred for TAVR. They found that 1/4 of the men actually had amyloidosis because they were doing pyrophosphate scans in these individuals along the way. So along the way, they were finding these patients had amyloid. And when you look at the amyloid patients, they look like what you would think would be the patients with more severe aortic stenosis. Instead, they had amyloid. Greater wall thickness, mass, lower stroke volume, greater diastolic dysfunction, abnormal GLS, So just keep your thinking caps on as to what might be driving this physiology of increased wall thickness, low flow, normal EF, et cetera. So what are our knowledge gaps with aortic stenosis? Symptomatic patients, are they cardiac? Asymptomatic patients, truly asymptomatic. What are the mechanisms of inflammation and calcification? What are the role of biomarkers? Keep your seatbelts on because not only do we have BNP data, but also troponin data. There'll be other biomarkers in the future as well. How to handle these patients with low flow, low gradient AS, and then the evolution of TAVR to lower risk patients. So I'm finally going to talk about TAVR for a few minutes here. SAVR versus TAVR, that one's pretty well settled, I think, at the current time. And I think the guidelines reflect what the clinical practice is, although the guidelines are always behind where clinical practice is going. And so what's been really useful is that although this took off quite rapidly in Europe, in the US, we were following very well-designed clinical trials, which you all have been part of, moving from prohibitive surgical risk to low surgical risk. And now we have the asymptomatic trials as well. But these data in these surgical candidates was quite interesting in teasing out the outcomes of TAVR versus SAVR. This summarized quite well in a meta-analysis by Siontis and co-workers a couple of years ago, European Heart Journal. Here are the outcomes. What favors TAVR, obviously, is the less atrial fibrillation and bleeding. Actual overall mortality was reduced. Vascular injury, pacemakers, issues with TAVR especially the pacemaker issue in young people, would favor surgical aortic valve replacement. So the age cutoff here is still a little bit uncertain, but younger individuals, long-term risks of pacemakers and unknown durability issues still would tend to point towards TAVR. But the more important outcomes of mortality and major stroke were equivalent. And so that's why you would then, for most patients, move to the left and consider TAVR. And so that's reflected in what you see in the STS database, where TAVR has truly taken off to astronomical levels over the last decade. And notice that it had very little impact on surgical volume in the orange. It was either SAVR or SAVR plus CABG, which stayed steady up until the low-risk trials got published. And at that point, there's been a decrease in surgical volume because we're doing more TAVR in low-risk patients as well. I think you probably had the same finding here. I mean, our vast majority of our patients are getting TAVR now, as opposed to SAVR. So the missing pieces are durability of transcatheter valves. Looking good so far, but we don't have 15, 20-year data yet. Patients with bicuspid valves, we're beginning to go there quite successfully. Extensive CAD, aortic aneurysms, associated MR/TR, still in the domain of the surgical approach. Younger patients, concerns about durability, pacemaker rates. So, what's the threshold? It differs between the US and the European guidelines. It's 65 age here, and it's 70 in Europe, when above which you would consider TAVR. Asymptomatic patients, and then how to measure TAVR quality. There's no good marker for TAVR quality yet, even though we have the TBT registry. What we do have are volume outcome data, which is obviously a surrogate for quality, by Mulapalli and co-workers from the TBT registry. The good news here is that this has been planned nicely so that if you want to get reimbursed from Medicare, you've got to get your patient in the TBT. So this is nice. We have pretty good collection, at least in the Medicare population, of all the patients getting TAVR. And so a good database upon which to sink your teeth. So this study was looking at the number of hospitals involved in TAVR and their annual hospital procedural volume. And so interesting was that hospitals performing over or under 100 or in this case 50, you can see that half of the institutions doing TAVR were doing less than 50 a year, and about 2/3 or more were doing less than 100 per year. And that translated into the early outcomes in these individuals in terms of mortality, 30-day mortality of whether you're doing 50 or 100 or more. Now, volume is not a perfect surrogate for quality, but I think what's reflected here are probably centers coming online. We were discussing earlier how you were the single center in Miami doing TAVRs, and now everybody's doing TAVRs. So there's more uptake. That's good. It provides greater access for patients, but there's probably a learning curve here, as well as perhaps some continuing low volume centers which may not be performing high quality work. But this needs more fine tuning to understand what the true volume outcome relationship is. So what are the challenges for TAVR? For me, it's the threshold is declining in clinical trials, registries, clinical practice. There's indication creep. There is a need for the multidisciplinary heart team. It's really should be built in, and you do that quite well. And I hope that we do it quite well also. Shared decision-making with the patient is also important. But of course, shared decision-making, if you're the patient, would always tend to favor TAVR. So it requires a really careful discussion of who are the right patients for this, because all patients want TAVR. And so that creates, I think, the biggest challenge for us. It's interesting in your thoughts on this, is when do you say no? I think the most difficult thing we have is saying that we really shouldn't do a TAVR. You're 30 years old, you're an excellent candidate for low risk surgical AVR under 1% risk with good long-term data. Not yet ready for TAVR. That's a trump card you want to pull out of your pocket a little bit later. Or the other patients who are very elderly, have very high risk comorbidities, so that even replacing the valve is not going to lead to a better quality of life or longevity. Very difficult to say no there as well. And so I think that's probably the biggest challenge that TAVR is now creating for us. Interesting is your thoughts on that one. And so I'm going to close with another iconic paper, this one from Paul Wood. I suspect no one knows who Paul Wood is in the audience, but when I was younger, we knew Paul Wood, who was the legendary cardiologist in London, who died prematurely in 1962. But in 1958, he wrote this seminal paper on aortic stenosis. And it's wonderful English literature. He starts out with aortic stenosis as a simple mechanical fault, which, if severe enough, imposes a heavy burden on the left ventricle and sooner or later overcomes it. That's nicely stated, except it's not the case anymore. It's not simple anymore. It's really complicated. You know, what's the physiology? What's this low flow, low gradient business going on? How do we identify who is truly a candidate for surgery? And then what's our treatment pathway going to look like? So it's actually quite complicated, and therefore quite interesting, and uncovers all of the gaps in our knowledge base which require further work. So for those of you interested in this field, there's a lot of work to do. So I'm going to close at that point. Thank you again for the opportunity to be here. Great honor. Again, a little bashful to be called the pioneer, but I do carry the torch. Let's put it that way. I'm carrying the torch onto you guys to make it move faster. Thank you very much.
Okay, I'd like to really thank Dr. Bonow for tremendous presentation. I've been listening to Dr. Bonow talk about valve disease for 30 years, as he said, and every time is really a treat and a tour de force, and I always learn something. So we're really delighted to have him for the rest of the day for the session, so we'll be able to interact with him. But at this point, I'd like to, on behalf of the Division of Cardiology, present you with this plaque as a pioneer of cardiology, which you truly are, and you've shown us. And we'd like to thank you for coming and spending the day with us. And thank you.
Thank you.